Welcome to Home Care Connection, a program brought to you by the Rutland Area Visiting Nurse Association and Hospice. The goal of our program is to educate and inform you about the many resources available when you are in need of medical or non-medical care at home. Whether you're recovering from surgery or managing chronic illness, RAVNAH's team of skilled nurses, therapists, and aides can help you recover and get you back on your feet. Today, we're living longer and living stronger, which is a positive thing, but living longer also increases our chances of living with a chronic illness. In fact, today, almost 1 out of every 2 adult Americans suffers from 1 or more forms of chronic illness. In addition, in 2010, 7 of 10 deaths in the United States, the people who died suffered from 1 or more form of chronic illness. It is estimated in 2011 that chronic illness will cost the United States over $1 trillion in healthcare costs. If you're dealing with chronic illness, stay with us, because my 2 guests today will help you understand how to manage chronic illness and live your life to the fullest. With me today is Cindy Wilcox, a home healthcare nurse with RAVNAH, and Lawrence Kopp with Care, a medical equipment company. Welcome to the show.
Thank you, Harry.
Today, what we'd like to do is we're going to be talking about helping patients cope with chronic illness. And so we want to get both of your perspectives because you both will help fill in the sort of full spectrum of services that people who live with chronic illness are available to. So Cindy, what we'd like to do is start with you and perhaps just start sort of, almost at the beginning and just say, what is chronic illness? What types of diseases can be examples of chronic illness? And so, what are we really talking about when we say chronic illness?
Okay, as the name implies, chronic is the direct opposite of acute illness, which is reversible within a relatively short period of time. Chronic implies long-standing and implies some sort of a day-to-day management. And a lot of our community members and our patients deal with these issues of how to cope, how to deal, how to manage an illness that just doesn't go away. You can't wake up one morning and poof, it's gone, yep, and everything is back to their idea of normal or their baseline. Things are definitely changing and not necessarily, unfortunately, for the better. There's this prevailing myth about the golden years of aging and how when you retire everything will be so much easier. And unfortunately, most of our patients get a very harsh reality check when chronic illness befalls them, because the golden years all of a sudden are very, very tarnished with day-to-day issues of mobility, of breathing issues, of just day-to-day functions of dressing and cooking and cleaning and getting out and getting moving around. All of a sudden those golden years aren't so golden. And the big question becomes, where do we go from here? How does our life change, and what does it look like versus how it looked before we became ill, with illness that just doesn't want to go away?
So in thinking about that, are there particular types of diseases or illnesses that sort of fall into the chronic categories? Or?
Sure. What comes to mind first and foremost, because of what we all need to survive, which is air and breathing and oxygen. The very first thing that comes into my mind in terms of dealing with chronic illness is what happens to those people who all of a sudden can't get their breath, have to struggle, or when they do get a breath, it's not a sufficient enough breath to make them feel like they have energy. And it's just a tremendous burden to them, just the act of breathing. All of a sudden that becomes their full-time management issue, is how do I just get through the day breathing? And the whole color of life changes at that point. And very often when one system has been affected in a very strong way, the body is built on a co-reliant plan, and if one system is affected, it's almost like a house of cards where one goes down, and then usually the heart will become involved, and usually from lack of mobility, the GI system gets all tangled up and jumbled up into a big mess that has to be sorted out. And your emotional system, your whole reason to be, your whole attitude about life plays into the fact that every little thing you do is such a burden. And before you know it, it's one system after another, and it's like a cascading waterfall of events that you just can't seem to grab a safety line anywhere to pull yourself back up. So it becomes a huge, huge issue.
So certain breathing diseases like emphysema or other ones like that would be considered a chronic illness?
Exactly. Chronic asthma, chronic bronchitis, cardiovascular disease like congestive heart failure, atrial fibrillation, and any kind of arrhythmia that can't be corrected. So these are some of the chronic illnesses that people deal with.
And diabetes is also a chronic illness?
Diabetes, then you get into some of your neurological problems like Parkinson's disease and multiple sclerosis, and Alzheimer's disease is neurological, that affects so much of our socio-emotional life. Things like Lou Gehrig's disease, part of the chronic.
So then it really does, I think what you said earlier about the fact that, it's not acute, like maybe I had a heart attack, but then I had a hospitalization, and now I'm sort of on the mend and getting back to whatever, or I had maybe a knee replaced or something like that, or something like that. This really is something that I'm going to have to find a way to live with.
That's right.
And no matter what I do, it's going to be there. Whether it's controlled or not is one thing, but I'm going to be living with it. So chronic illness really is something that becomes a part of my daily reality.
If I can just add one thing.
Absolutely.
With a chronic illness such as COPD, where you have emphysema possibly, or chronic bronchitis, it's even when you're sleeping.
Sure.
You're just never left alone from the effects of the illness.
No, I think that's important because one would think then that that the barriers that one might face for dealing with chronic illness would be significantly different from what they would be dealing with an acute illness.
That's correct.
So are there, what types of barriers do you see in your day-to-day work with patients that prevent them perhaps, or that just simply get in the way of them managing their chronic illness?
Right. I think for my experience, what I have come to the conclusion of is the people that I see who are the least prepared to deal with a chronic illness are those people who have had no experience dealing with a chronic illness. It's like when you are first hired to do a job and you come into your workplace and your manager says, okay, this is your first day on the job, get to work. Being expected to know exactly what the procedures are, what the policies are, what exactly you're supposed to be doing at what time, and so on and so forth. If you are not given a proper orientation, if you're not given a proper training, if you're not given a proper education, how can you possibly be expected to know how to manage your job? And unfortunately, with a chronic illness, and I say unfortunately because people think, oh, I'm done with my 9-to-5 job, now I can do whatever I want. And then when a chronic illness befalls you, all of a sudden it's 7 days a week, 24 hours a day, no vacation time, no days off, no holidays. I have to deal with this illness around the clock, and I never get a break from it. And what training do I have for this?
Sure.
I mean, and what becomes to my quality of life? It's great to live a wonderful, long life, but if you can't live a life that has some self-defined quality, is my life worth living? It becomes many, many times the issue. And so what also enters into the equation is, what is the prevailing attitude?
Sure.
I always say, I like to wake up every morning with an attitude of gratitude. That's kind of like loving oneself enough to realize that one is grateful for the gift of life. And if you can start from that reference point, then you can say, yes, all of these challenges are in front of me, but I'm alive, I'm here on the planet, and I'm jolly well going to act alive. So I'm going to take responsibility for that portion of my life that I can manage, I can possibly manage. I'm going to learn about my illness. I'm going to learn what the prevailing treatments are. I'm going to go on the internet. I'm going to get the visiting nurses involved. I'm going to know what my resources are. There's so many things that can be done to help one cope with the day-to-day management. But it all starts from a motivation of, I have life, I want to live, and I want to live to the best of my ability. And then your support system. I've never seen anyone do well in the home care field. I've never gone into a home that I thought a person was doing well that had a chronic illness and had no support system.
Sure.
No friends, no relatives, not even so much as a cat to sit on your lap and pet at night when everybody else is gone and you're all alone, to keep you company. I mean, I really worry about, so many nurses go home every night and they agonize over what circumstances they see during the day. How can this person possibly manage with this limited kind of existence and no one to help them? So yeah, there's a lot of things that go into good management of a chronic illness.
Well, and I think that, you know, you triggered a couple of thoughts in my mind that I'd just like to put on the table, maybe even for both of you, because, you know, one of them is, you know, quality of life. And I think that, you know, one of the things that, to me, is true about what we're going to be talking about today for both the services that you provide patients individually and collectively, is really about quality of life.
Right, exactly. Our to the best of our ability, our job is to help the patient get to a point where they were prior to the diagnosis of whatever it happens to be, whether it's congestive heart failure or COPD. Not that we're going to fix the disease by any means, but to be able to get them to a point where they're able to enjoy their life again in a way that's close to what they were able to do previous to the diagnosis.
And the second thing that you also touched on, you know, was about, you know, managing. You used that word a number of times, you know, and I think that's important. I've had a couple of friends over the course of time, specifically in this case, two people I'm thinking about, both had diabetes. And they were both, you know, relatively young when the diabetes was diagnosed. And at the beginning, when they first found out about it, their sort of their lifestyles, their level of understanding about the disease, how it works, what its impact is on them physically, was really what they struggled with. And as they gained more knowledge, more information about the disease and the way that it works and the way that they could manage it, they managed the disease, and it became, over time, it became less and less of an impediment to them sort of living the quality of life that they wanted to.
That's
right.
That's
Yep,
a good
absolutely.
point.
So is that consistent with what you see when you work with patients?
Yeah, absolutely. And my parents' generation, I have to address that a little bit. Children today and young people today are really taught about their bodies, and they're taught about how to ask questions in a healthcare setting. A lot of times I see very passive kinds of experiences that people don't seem to have a sense that they have a right to know about their bodies and how they work, and that they have a right to ask their healthcare providers for this information, and that they really do need to become actively involved. And barring, some kind of dementia or some other type of brain damage that doesn't allow them to understand a process, there should be no reason why anyone can't get actively involved or have an advocate, being a close family member or a neighbor or someone who cares about them in an informal, non-sort of healthcare provider related way, but someone who really cares for them, who will take the interest to make sure they're taking their meds properly, to make sure that they're getting up and doing the things that they need to do every day, and eating the right foods, and maybe bringing them a meal, and those kinds of things, because you do get to the point where it's just too hard to manage every day by yourself, from what I've seen, and you really need the additional supports. Without the support of other people, when you cannot always do it for yourself, if as much as you can do it for yourself, you should take it upon yourself to become as actively involved in your own health as you possibly can. I always start from that premise and take it wherever the patient will allow me, as far as they will allow me. If sometimes I can't get past square one because they don't have a desire to do it, and then you look for family or friends to do it for.
Right, and sometimes what we find is, actually I've been hearing this quite a lot this week, of "I am so sorry to bother you." Well, that's what we're here for. Please bother us.
Right.
And in fact, when we first encounter a patient, we expect for the first month or so, and in fact, the frequency of our visits to the patient are going to be more frequent in the beginning, because we're expecting questions, we're expecting concerns. But there is. And I guess maybe it's a generational thing of, I should be able to do this by myself, and I really don't want to have to bother somebody else. And that's probably as big an obstacle to overcome as anything else. And so involving another family member or involving a neighbor is an extremely useful thing, particularly for the patient.
Well, and in fact, one of the reasons why both of you are on the show today is because, in fact, we are talking about people who have had the ability or the desire to choose to receive their health care at home. And so it does in some ways speak to an independent spirit. It does speak to people who are seeking, who define the quality of their life to a certain extent by their independence. So I think it makes sense that they might be a little reticent to ask about, all right, you gave me this thing, now I should be able to do this on my own. I mean, we at RAVNAH we work with a number of patients that suffer from chronic illness, but we're not in a house 7 days a week, 24 hours a day.
Right.
So when you go to see a patient, with respect to what your normal interaction would be with a patient with chronic illness, it's not really a day-to-day thing. It's more educational than not. Is that fair?
Yeah, I think about 15 or 20 years ago, the whole emphasis on home health care shifted from the nurses doing to the nurses teaching patients to do, or teaching family members to do for the patients. I mean, it became a budgetary issue in terms of, how much is this going to cost to send
Sure.
a nurse to do this every day when the nurse could be doing the teaching of the family or the patient to do it for themselves, as long as they were able and willing, not and or, but able
Absolutely.
and willing. And if you get the consent and they are completely cognizant of what you're telling them to do, and you give them a demonstration on if it's a changing a leg bag on a catheter, and then you show them and you watch them do what you've just shown them, or teaching them how to do an IV med administration, as long as they can return demonstrate, they're considered golden. And then beyond that, you teach signs and symptoms, you teach about the illness itself, you teach complications to watch for that they need to report either to us or to the doctor, and you give them written information that you can actually take into the home and go through it step by step with them, and because if they're like me, I mean, somebody can go through a big laundry list of do's and don'ts, and
right.
6 hours or 2 hours or 15 minutes after they leave, I've totally lost 3/4,
Yes.
if not all, of what they've said to me. So if it's in writing,
Sure.
you can go back and refer back to it and say, oh yeah, I remember she talked, drink enough fluids, eat smaller meals more often, decrease the amount of gas-forming foods you eat. I remember she talked about that, but there it is in writing, so you have a reference point.
That's great. So, and again, I think, Lawrence, part of what I'd like to find out a bit about, and perhaps you can let our viewer know, is so when you go into a home, what are the types of things that you do or that LinCare does for patients that you see in and around Rutland County?
Okay. As far as the types of equipment, or as far as what the staff does?
A little bit of both.
Okay. As far as equipment, we can provide everything from tube feeding to hospital beds, wheelchairs, oxygen equipment, of course, breathing treatments via a nebulizer, as well as the medicines themselves. Let's see, I know I'm forgetting something. Oh, and CPAP machines for people that have obstructive apnea. They stop breathing in the middle of the night. But in addition to that, that's the equipment side. One of the important things that we do is we send a respiratory therapist into the home, generally 48 to 72 hours after everything has been set up. During the setup process, whether it's a technician, whether it's myself or the center manager, there's a whole booklet of information. Some of it we leave behind for the patient to look at when they're on their own, and some of that is things, for example, the change with your lifestyle, or what to know about oxygen or nebulizers or what have you. But some of that is kind of lost my train of thought.
Just, you were just talking about the types of equipment that you bring into people's homes and how they use it.
Well, again, the respiratory therapist is the primary job is to teach the patient, but we're also going through a checklist that we'll leave behind with the patient to make sure that they understand everything, and again to check up afterwards to make sure that they can still do what they were able to do 2 days ago. And if they're having any issues, whether there's mask issues related to suddenly they've developed a rash, or something else is going on, excess mucus, things of that nature.
And, I'm guessing that things like a nebulizer or these oxygen devices, they must be extremely large, and probably it traps me in my house almost exclusively? Or
Exactly, and that's the thinking about it, but it doesn't have to be that way.
Really?
Yeah. Actually, there is, this is the latest of the portable oxygen units.
Wow.
This is one of the issues with liquid oxygen. It's in a reservoir that you keep in your home. We'll come and deliver fresh oxygen every week or 2 weeks, depending on how much you're using. And one of the benefits of this system is to fill it, you have to match the bottom with the reservoir.
Sure.
And you press this lever, and for most of these systems, you're listening to see when it's full, and you have to hear a certain trigger.
Okay.
Not everybody's hearing is as good as it used to be. This one shuts off by itself.
Wow.
When it's full, it's full. And then you measure how full it is, you pull on this strap, and it turns green if it's full, and if it's empty, it looks like that, which this one's empty. And this one on a patient, typically for oxygen patients when they're first starting out, and hopefully they've caught the disease at an early enough stage, the patient's going to be on a liter flow of 2. And for the patient that is able to, now there's 2 different flow types. There's one where you turn this on and it's flowing all the time. There's another that makes this last longer, because this will only last about 2 hours in that event.
Okay.
But if the patient's body is able to tolerate a pulse dose, and what that means is the oxygen is flowing when the nose demands it through the nasal cannula.
Okay.
And this will last closer to 8 hours.
Wow.
So imagine, carrying this thus, or it might be on a belt, or it might be over a shoulder strap. We actually had a patient. One of the issues that many patients face is they're suddenly embarrassed to have equipment and to be that person in line at the grocery store that's making a noise because they're breathing.
Okay.
And it happened with this particular patient that she discovered one day looking in the mirror that if she wore her glasses at the end of her nose and had the cannula coming down here, because the glasses are at the end of her nose, nobody's going to notice. And she's right. So, but again, the idea is to bring the patient back to the state of them being able to get out and about and be active and participating in the things that they used to participate in and enjoy.
I mean, but that, I think that I remember I was probably about, I was around 7, 8 years old, and my father was suffering from a number, actually, of chronic illnesses prior to his dying. And we used to have oxygen in the house, and they were these gigantic tanks of oxygen.
Yep.
And whether he, wanted to or not, if he needed the oxygen, he was going to be at home.
Right.
And I mean, you talk about promoting independence for patients who are, again, managing chronic illness. This is a level of independence that I think is just wonderful.
Now, for somebody in my neighborhood, back a few years ago when we had that Noricane, it was about this time of year.
Yeah,
and
sure was.
Rutland was in a state for a period of time.
Absolutely.
We were out of electricity for a week.
Right.
And in that situation, this is a system that doesn't use any electricity at all.
Unbelievable.
And so that patient, as far as their oxygen is concerned, it's flowing. They have no issues, no concerns.
I mean, to me, that's just unbelievable. And you actually have another device with you, do you
I
not?
did. I brought a little portable nebulizer.
I just think...
Now, this is not everything. This is not all that's to it. But what else is to it is really not much of anything. There's a patient that I refer to when I'm speaking about this, because it's so neat that what she had previously was a nebulizer that honestly was about this size. And it plugged into the wall, and there was no way for her. She'd get up in the morning and she'd have a treatment, but about 4 hours later she'd have to have another treatment.
Right.
And in this case, she has a relative that she likes to visit in the Middlebury area. So while her husband is driving, she's plugged into the cigarette lighter in the car.
Unbelievable.
And when she's home, she's plugged into the wall. And this works as well as any. And there's actually, if you want to, now typically insurance and Medicare won't pay for this, but there is a battery that attaches here. So if you're absolutely out someplace where electricity is going to be an issue, it's not necessarily going to be an issue.
And again, I mean, what really strikes me is that when I think about the work that Cindy does and the work that you do with patients, it really is about restoring and or providing education. You both provide education to patients on the illnesses that they have and on the equipment that they're using, and how that's going to improve the quality of their life, improve their independence.
And for us, sometimes it's also assessing. We do a full-page assessment on patients when we first meet them. And part of the purpose of that is to see what is their lifestyle in their home as they are right now, and how can they adapt the equipment that they're getting, first of all, with the lifestyle that they have, with as little interruption as possible. So at one point we met a man who was a carpenter, and he suddenly woke up one day and realized, I don't think I can breathe properly. And it turned out from all of the dust that he had breathed in over the years, that was an issue. And so something as simple as, you really need to be using a mask when you're doing this type of work. We can't make your lungs better, but we can stop. You can still do your carpentry, but with the mask you'll stop doing damage.
And what I'm going to say is, first, we're out of time.
Okay.
But what I'm also going to say is that I think the story of this show is that chronic illness may well be a unwelcome but real part of a number of Americans' lives. But through the services that RAVNAH provides, through the services that Care provides, the quality of life of people suffering from chronic illness can really be one that is independent, that is empowered, and that really speaks to an excellent quality.
It's not a death sentence, and it's not house arrest.
Absolutely.
That's very true.
Thank you for joining us on Home Care Connection. We'll see you next time. I'm Harry Snyder, your host.